Perfect. Thank you. Okay. In today's session, we're going to be talking about skin and soft tissue infections and how to care for those and also prevent them. Our speaker today is one of our very own amazing subject matter experts, Dr. Troxler. So Dr. Troxler is the program director for an ACGME accredited addiction medicine fellowship at the East Tennessee State University. Her team is engaged in an intense, eager group of individuals with an unbridled commitment to helping others find their way through the tangled relationships they have with substances and maladaptive behavioral responses to a place of acceptance, healing, and hope. They do this by being a team of talented, dedicated interprofessionals. Currently, they have a certified peer recovery specialist, social workers, certified medical assistants, board certified psychiatrists, preventative medicine and family medicine physicians who are double boarded into addiction medicine, social work students, family medicine, psychiatry residencies, medical students that are all contributing to this stellar work and stellar team. Next slide. Now we will move into the presentation and I will turn it over to you, Dr. Troxler.
Super, thank you. It's been a little crazy and hectic. I really want to be snowman number 5. I really want to be that snowman. Or even number 9. It would be fantastic, but I am definitely the melting and falling apart snowman number 1. So when we go through this presentation, I might be just as surprised as you by the next slide because I haven't looked at it since I put it together. So awesome. At any rate, more than anything, I just hope that you appreciate the aesthetic of the presentation, because sometimes for me that matters more than the content. So off we go. Next slide, please. So today the things that we're going to cover is prevention, early identification, and interventions of these skin and soft tissue infections when we find them. Next slide. And so just to kind of think about what are we talking about with skin and soft tissue infections, they're localized. So these are very, like, it's here. It's not all over the place. It doesn't have systemic symptoms. I'll talk about that a little bit more later, I think. And basically result as a break in the protective barrier. The skin, our largest organ, the thing that helps keep all the dings and dents on the outside and nothing going on the inside. But when we break that protective barrier, we have the potential of introducing things that we don't really want on the inside from the outside that could be intentional, like where someone is using a syringe, or unintentional, we fall and scrape our knee. Some of the things that can happen, though, downstream from a skin or soft tissue infection, where it goes from not being localized to something like endocarditis, where we have an infection from something that's gotten into the bloodstream and it's seeded onto the valves of the heart. So endocarditis, septic thrombi, that's basically when you've got a plug of infection that is broken off and is getting showered throughout the body, many different places it likes to land. Any place it lands, it causes problems. And then just simply having bacteria floating around in the bloodstream, but it can also include fungi, which is really not pleasant to have inside the body running amok through our streams and hitting into our cells and organs. Next slide. So how do we prevent this from happening? Next slide. And so this is a little bit of a rabbit hole I went down just because, harm reduction, we keep using it, but I think all of us feel like there might be a ticking time bomb on how long that those words are acceptable and allowed, and we still get to have funding. I don't know, whatever. Every day feels like new hazards are thrown our way. So harm minimization, that's fun. Risk mitigation, I feel like that's something we all have to do every day. Injury prevention, illness prevention, I think that's a nice way to think about it. But my favorite is gradualism. So many words we can come up with to describe things, but I feel like that also describes a lot of the work that we do anyway. Like gradually, we're going to get to a different place. It's just going to take a minute. So gradually moving from where we are right now to maybe reusing needles, sharing needles, not having things to clean my skin with, sharing pipes, whatever, right? We're doing things that are gradually we're going to change and do something different. And hopefully by interacting with those of us who attend echoes like this, people will be able to do that sooner, better, faster. Next slide. So this is completely a grab and drop into a slide and very tiny on the side, and it's at the end as a resource. This wonderful book that it's a book of different ways to engage with wound care and medical triage for those who are experiencing a lot of the things that we see when we're running an SSP. So individuals who are unhoused, individuals who are using substances in a myriad of different ways. This book basically runs through all the different ways to do it in a safer fashion, but it also gives us an idea of what to be looking for. It's a wonderful manual. So things that when I first started doing the work in the space that I'm in, as a physician, sitting down with a patient and saying, like, do you think you could smoke that instead of inject it? At first, it was like, somebody is going to come and shut me down because I just told people to smoke their drugs instead of inject them. But truthfully, that is a harm reduction approach, and maybe that is something that the person in front of me was like, oh, well, I could. That would be safer for me. And then even like, no, I'm going to continue to use a syringe, a needle. Well, then how are we taking care of those? Do you have access to an SSP, or are you having to reuse needles? So let's make certain you can do it in the safest way possible and decrease the risk of introducing any of that bacteria or fungi into your system. So this book is a really great rundown of things like what's the best way to clean my syringe. So next slide. This is another grab and drop because one of the things I trip into this myself. It's individuals who are currently actively engaged in substance use or other dysregulated means of coping. Um, they're experiencing a lot of things on the daily that I don't. They have experience and knowledge that I don't. And so a lot of times I learn amazing things from the individuals in front of me, but I forget that sometimes I might have knowledge that they don't have. Something that might seem obvious to me isn't obvious to them, and vice versa. It's obvious to them, but it's not obvious to me. And so just recognizing we all have something that we can share with one another to help each other out. Um, like how to take care of your veins for the long term. Like if we're gonna use them, let's take care of them so that we aren't having to, because we can't get a vein, we're having to go to skin popping or direct IM intramuscular injecting, because that is where some of the biggest problems can come, especially when people are putting substances into their muscles, where we see some of the biggest, nastiest wounds. I've got a patient who was doing that and has a graft that never really took. Years later, we still have kind of an open edge on that skin graft from where he had been injecting intramuscularly. So some of the worst wounds I've seen have come from that. So just how do we take care of our veins? So again, this is a direct grab and drop from that manual I was telling you all about, which is now beautifully linked in your chat. Yay. Okay, next slide. And this is a picture of it. And if we could click it, it would open it up. And can we click it and open it up? Will that work?
It's not working.
Okay, that's all right. So
Allie, if you use the link in the chat, because I think Menti kind of cuts off links when you're in present mode. But if you click the link in the chat, it should pull it open potentially. You'll just have to drag it to the screen that you're sharing.
am I doing that? No, not
Allie
me.
should be able to.
Okay.
Yeah.
Because I'm not clicking anything. Okay.
There we go.
Cool. Thank you.
Technology.
Oh, it works better when we all work together. If you'll scroll down a little bit and just kind of go into the table of contents right there. Um, I just wanted to demonstrate like how much information is in this. And you can see where it's like, it's like almost 100 pages. So I do think there are probably some things in here that are worth like maybe pulling and sharing with individuals or using it to develop some handouts for people. But it's pretty comprehensive. I mean, it goes over monkeypox. But just things for us when we're out in the field or we're in our clinical setting or we're working on developing policies and procedures. I do feel like this is a good resource. Even things like, injecting tips, how to avoid missed shots, how to stay out of arteries, what does it look like when you've gotten into one, hitting nerves, ways in which to make skin popping safer and less painful. What is an abscess, what we're going to be talking about today, abscess look at. One thing I don't hear anybody, I don't hear people out on this side of the Mississippi talking about cotton fever. But it covers cotton fever in this. I just wonder, kind of curious if you guys hear people talking about it much, but it's not something I've heard since I left New Mexico. That's where I first came across the idea. Um, Cotton fever is a thing, but so it's a lovely resource. So I highly recommend it. And we can go back to the slide deck now, please. Thank you, Allie, for sharing that. And the next slide. So, okay, we've done all of our harm reduction interventions, measures, been encouraging, gave great handouts. People are trying, but stuff happens. So if it does happen, next slide. This is kind of what we're looking at, a nice little cartoon version. I didn't know the depth of stomachs and how graphic pictures I could share. So there's a little bit of this and there's a little bit more live action photos. But this cartoon, I think, really gives a good sense of what we're seeing, what it is, and what that could be. So there's actually 3 different ways of looking at this. One of my favorite is erysipelas, just because it's a fun word to say. It's a weird one. Erysipelas is totally in the upper layers of the skin. It tends to be raised and red, like red and shiny and really painful. As you can see, as we go down the line where we've got the abscess, which is the one on the far right of your screen, you've got that lovely pocket of purulent material that is just waiting to come to the outside world. And that is something you can do something with. These other 2 where you've got erysipelas or cellulitis. Cellulitis goes into your deeper layers of skin all the way down into sometimes into the subcutaneous fat layer at the basement of your layers of skin. That one is a duskier color. It is also painful, but it's a sharper, brighter, the way I would describe it, pain that you get with erysipelas. It looks like it hurts. Cellulitis looks like it hurts, but erysipelas is like, ow, are you okay? But you can see with those 2, the left and middle pictures, there's nothing to drain there. Nothing. So you're not going to go poking in that. You're not going to go squeezing on that. You're gonna put some antibiotics on in that. You need somebody to take them. And then with your collection of pustular material, there are ways in which we can help people get that on the outside. If you will go to the next slide, please. Okay, here's our live action photos. So cellulitis, this is what it looks like. There might be some abscesses brewing with a couple of these, especially the ones that are on the right-hand side of your screen, the leg and I think that's an elbow picture. You can kind of see a collection of a little bit darker and maybe a central opening or wannabe opening on both of those images. The one in the upper left is exactly what it looks like when I get a wasp sting. I always get cellulitis, yay, with wasp stings for some obnoxious reason. You can even see a little bit of a white ring around that one, like there might be an allergic component like this, and the central mark in that really looks like somebody got cellulitis from a bug sting, which is why I want to bring out, like, you may see this absolutely not related to injection use. So being aware of these things happen, it doesn't mean a needle was involved. It could, but it doesn't. It's not a required element, which I'm just going to go ahead and asterisk caveat that with when individuals with known substance use disorder come into an ER and people see that on their chart and people will just go ahead and assume, and it's like not always the case, and quite often not the case, but it can be the case. So at any rate, you're going to treat cellulitis and erysipelas and abscesses the same way regardless of the cause. You're going to treat them the same way, but there might be other things that you pull into play because that is part of their history or it's a part of the mechanism of injury that resulted in the infection that you're treating. The bottom picture, that lovely, I don't even know what body part that is. There was some questionable stuff going up on the upper corner, which is why my circle one is covering it because I really do not know what part of the body this is. But I wanted to show you guys that blistering. We often see that in MRSA infections. It's not uncommon to see a blistering and a sloughing with MRSA. It is tempting, and a lot of times people do culture these, and I don't think that's something we'd be doing out in the field, but oftentimes what it reveals is skin contamination. Sometimes we will get MRSA positive, and that's exciting. We're going to treat it the same way anyway, but you can have some of these telltale signs that's going to make you want to treat for MRSA anyway, minus having a culture to show you that's what it is. Next slide. And then this is erysipelas. And I think hopefully this picture gives you guys a good idea of why it looks different from cellulitis. There's a duskier quality to the cellulitis pictures than there is to this erysipelas. You can see the shininess, and it's not great at demonstrating this, but I think you can see how it's a little bit of a raised, it's raised. It's a little bit higher than the uninfected skin. And that is definitely the redness, the shininess, and then that raised quality is what makes you think it's erysipelas. There's probably a slide that says this. I always get ahead of myself and then it's in a later slide, but erysipelas most commonly is on extremities, arms, legs, and face. Really likes the face. Next slide, please. And then yummy abscesses. So you can see them in different stages here. Some of them look a little bit more ready to act on than others. The one in the upper left is already draining some serous fluid, and that's not really the pustular material so much. It's kind of this straw colored exsanguinate that's coming out of the lesion. And then one on the bottom right, it looks like it probably has drained, but we still have some leftover infection. It is not uncommon to see cellulitis with your abscess. The one in the top right, we've got a really localized abscess there without surrounding cellulitis. So it can present itself in so many different ways. The one in the bottom left definitely looks like it could be ready to roll. There might be a couple of abscess pockets because you can kind of see two areas of potential drainage going to happen in those places, along with a little bit of cellulitis surrounding it. And then the one in the very middle, the color of the picture makes it a little bit hard to see because it's just a lot of red, but it does demonstrate one of the favorite things all of us who get to see and treat skin infections do, which is draw circles around it. Because you're going to draw circles around the edges of the infection and you want to watch for reduction. And this is actually a really good way to, advise people, whether you've seen them in office or out in the street. Like I've drawn this circle on the infection. If it goes outside, if it starts spreading beyond the circle that I've drawn, you need to go get immediate attention because whatever we're trying to do for it isn't working and it's spreading. So you need to go and be seen sooner rather than later. So the circle is actually really helpful to help guide people on are we getting better or are we not getting better? So next slide, please. Okay, why does it happen? Don't you love my little introductory and break next? So it happens because of vascular injury. So the substance itself or any dilutants or contaminants that have joined the ride. So you've got something in a syringe, it's pushing the plunger down, it is entering the vessel via the needle. So the direct toxic effects of the substance, as well as anything that you've mixed with it or anything, like I said, that's along for the ride that's contaminant, whether it be Clostridium, that's, there's some dirt that got in there and that's in there, or some staph. So there it is inside the vessel now, and it just causes a direct inflammation just because of the chemical substance being in a place it doesn't normally belong. Endarteritis. So the inside of the vessel is inflamed because of contact with an irritating chemical. This results in endothelial injury. And whenever you've got damage going on inside of the vessel, platelets are going to be like, oh, me, I want to fix this. And they're going to run to the area and try and tamp down whatever's going on. But by them being there, so you've got this inflammatory irregularity in the vessel wall, and then the platelets are coming along to stick themselves on there. So we've got an even more irregular inside of the vessel wall, and it's stuff that's just kind of come and glommed onto other stuff. And so it may not be stable. And so you've got blood rushing by constantly, and little pieces of this will get flecked off and thrown around, and that is your thrombosis. Or your embolism. So you've made this thrombus, and then you've got emboli, these little pieces and flecks that are going to come off of that wad or your thrombus. And then just simply because you've got all this injury and inflammation, the vessel itself may spasm. So it's going to clamp down because all these things are going, it's like, we're just going to shut down, just shut down. And so what that does is it decreases blood flow. So between a thrombus and vasospasm together independently, you're not getting as much blood flow to the tissue, and therefore those cells that should be fed downstream are not, and they're going to die, and that results in necrosis. And all of that makes a really yummy medium for bacteria to grow. It gives them something to feed off of. So that is kind of the cascade of with just putting something into a vessel, you can end up in trouble. Next slide, please. Okay, this was the best graphic I could find. It's got a pair of like pickups and a scalpel where just simply like even planned surgery, cutting into a vessel, what can happen? So if we think of the surgical insult, instead being a scalpel or a pair of pickups, being a needle, that simply breaching of the vessel can result in things like the shear stress of the vessel wall, the inflammatory mediators coming in, like our platelets. This is one of those areas of medicine where I'm like, oh my God, somebody else can do that. Because anything, when it comes to things like hematology and immunology, like, peace out, that's somebody else's department. Um, but it can also result in hypoxia. So we don't have enough oxygen in the area. And that's another reason for cells to kind of go into shutdown mode and not function well. And that stresses the environment. We've got white cells maybe coming to join the party. And then we've got this fibrin clot type thing, or the thrombus that's going to happen. And it also demonstrates the vasospasm. So this is just kind of a picture of what might be happening inside of the vessel and why things can go a little sideways. Next slide, please. So some of the infectious contaminants and some of the more common things we see, top of the list, Staph aureus. There is methicillin sensitive Staph aureus, so MSSA, and then there's methicillin resistant, MRSA. And the one that gets all the attention is MRSA, but MSSA is still an infection that needs to be treated because it's doing something it's not supposed to be doing. We're colonized with these things. I dare say the majority of us are colonized with MRSA, but because we don't have breaches in the skin significant enough, or our immune system is strong enough, we're able to not get an infection because of these bacteria that just live on us anyway. But when nutritional status, high stressors, frequent injections are happening, frequent injuries are happening, then these guys can get a foothold and a leg up on our normal barriers to keep us from getting infected. Strep pyogenes is also common on the skin and can cause infections. And then things that you might find, whether it's in the dirt and not the cleanest water, towels or scraps of fabric that you may be using to wrap your equipment in could carry some Clostridium or Bacillus, can carry fungus in there. And so then it's on your equipment, and then it's going to end up inside the body. Next slide. So what can we do to turn the ship back around and get it going in a good direction? Next slide. So our SSPs offering wound care clinics. So it's a really good way for someone that feels that they're in a comfortable space where they have people around them where they feel like, I can trust you, I can share this with you, because of the relationships that happen over time. Or even if it's a new person coming in, maybe they've been brought in by a friend who's endorsed us, they vouched for us, like, these people can help you, they'll take care of you in a non-judgmental way. So our wound care clinic, seeing it before it gets really horrible, is a good way to intervene. But then things like nutrition, housing, any unmet medical needs, because all of those things can inhibit healing and encourage wound development. So if you are living in the rough and having to go through a bunch of bushes and you're getting scratched up, those are open sources of infection. It's a breach in our defense from getting these things inside of our skin and into our bloodstreams. Something as simple as being scratched by a rose bush could be enough, especially when someone does not have good nutrition, or someone who's got diabetes and they're not on appropriate medications. They don't have a way to check their blood sugar. They don't have access to the medications. We all know those individuals have difficulty with wound development and slow healing. So addressing these risks associated with that can help improve outcomes and possibly avoid having some of these things happen anyway. The education on safer practices, that wonderful handbook that we were looking at earlier, just how to do what you're doing in the safest way possible. And then ongoing care. So is there someone in the community, like, the SSP, we've checked you out in our wound care clinic, we've done what we can for you here. You need to follow up those sooner than we're coming back. Here are some people, this is a place we know. Um, this is the way that we have to transport you, depending on what your own access to resources is, what you might have. One community is different than another community and what they have and what they know they have. So it's also part of our responsibility to maintain updated rosters in our head, in a binder, wherever, of what's available in the community that we're serving at the time we're there. Next slide, please. So good ways to care for the skin. Saline, I know it's something we love to staff, not the right word, to stock, that's the one, in our SSP vans. But they have done studies. Saline's great. It's great for a lot of things. Like, it's good for, like, nasal saline flushes. You can rinse out your eyes with it. It's good stuff. But when it comes to cleaning a wound, tap water, studies have shown us tap water is just as good as saline. And tap water might be easier to come by, especially if, like, here's a little box of saline, and within 2 days it's gone, right? So if you're trying to keep a wound clean and the only thing you think you can use is saline, you're going to run out of supply. But if you have access to potable water, um, then you've got exactly what you need to clean your wound with. Soap is great. Using things like alcohol and peroxide, not advised, because that is going to kill the good cells, the healing cells, the granulation tissue, all the things that we want happening in that wound, as well as bad stuff. So soap is your best friend. And sometimes soap and potable water are also difficult to come by. So I think it's important that we have, like, the bottles of water that I see on the vans. I think that's great because you can drink it. You can pour it over your wound. You can refill it whenever you get to a faucet. So that's a great thing to have on hand. But soap, alcohol wipes, those are important for individuals who are injecting, so they have a way to clean the skin before they inject, and then providing them with any type of bandages or barrier materials to help keep a wound or a potential injury spot. Like, I cut it, I hurt myself. But this is something I'm going to put over it so that the outside stuff isn't going to get in any of that bacteria, so that we can keep the wound in good shape. Next slide, please. So kind of to loop back to the first slides we had, when we're thinking about our skin and soft tissue infections, dermal, subdermal, abscess, like, exactly what are we looking at? What do we have? Is it still a localized infection? Is it spreading? So that circle that we talked about earlier, it's I don't know, as a physician, I get a kick out of weird things. I like drawing those little circles, and I like seeing it shrink in, or, like, it's getting bigger and I know I need to do something more for this individual. Um, but also advising, educating the individuals we're seeing on what the signs are of systemic spread. Like, are we starting to nudge up towards, am I worried about this person becoming septic? So anytime somebody's describing to you things like chills, hot flushes, feel like they have a fever, they feel kind of fluish, achy, maybe a little bit of confusion or more fatigue than what they're used to, those are all like, let's not second guess ourselves. They need a higher level of care, and the sooner the better, because we want to be able to rule it out and get in front of it. Because once we are on the sepsis train, it's not an easy one to get off. It's not a fun ride for the individuals who are there. So if we can do something to identify it earlier rather than later, that is the goal. And then, as I described before, endocarditis, where we're getting heart valve leaflets infected, they get these lovely things called vegetation. And because those heart valves are continually flapping and you've got this little thing hanging off of it, you can imagine how it's just going to, like, fling, fling, fling. So these little chunks of those thrombi become emboli. Heard myself talking. Become septic emboli, and they go places like the brain, the spleen, the liver, the heart, the lungs. They go everywhere, and we don't want them there. There's these lovely little things called Janeway lesions. So when these little septic emboli get all the way down to the very end of capillaries, you can see, like, red. You can see, like, these red, like, splinter hemorrhages, or there's, like, red tender spots on people's hands or the soles of their feet, because small emboli have gotten all the way down the vessel into the capillary. Um, so if someone shows you something like that, one, I don't think they're going to be up walking around, to be honest, but I have seen some incredible physical resiliency in our patients. So they might be. So if they're showing you tender red spots on their hands or their feet, they need to be evaluated at an ER immediately. potentially. I mean, take more history, not just, take more history, but that could be a downstream sign of some septic emboli. Next slide, please. So when you are treating this, and if you have the capacity to provide treatment, depending on how you're staffed or what type of facility you're in, you're going to just straight up give oral antibiotics for cellulitis and erysipelas. This picture is an interesting picture because it shows you how to treat an abscess, but I have a caveat with that, in that it's it's kind of a funny image because it's like left, right, up, down. They do the lettering weird, so I'm going to talk you guys through it in just a second. But the definitive treatment for an abscess is drainage. You don't need antibiotics for an abscess. You can simply treat it through drainage. I will typically do antibiotics and drain, depending on the status of my abscess. And you can get it to drain either surgical, like what you're seeing in your lovely little cartoon, or via encouragement. And what that is warm compresses. They need to have access to warm water and a piece of fabric. If they can soak it, that would be great. I love using Epsom salt as an astringent to kind of help pull it to the surface. So that's another thing. If there's Epsom salt available, maybe something to staff on your van or in your clinic. But really just warm water on a compress will do it. So again, we need to have access to water and a way to keep it warm. You could do hot hands or something like that, but really moist heat is your best, because it kind of helps. It helps to open the capillaries on the skin. You kind of get a dilatation of structures within the skin. The pores will open, but the moistness seems to do a little bit of kind of encouraging breakdown over an already irritated layer of skin, and it will more easily open. But just heat will get you there too. So if it can't be moist, just go ahead and do some heat on that abscess. So this picture shows the provider using what is lidocaine in that syringe and needle. That is lidocaine. So they're going to anesthetize the abscess before they incise it, which is the picture C. When you have an abscess, you have inflamed, leaky skin cells, and they are not going to hold the lidocaine, and you're not going to get effective numbing, and it burns. It burns like fire. It is miserable. I don't inject my abscesses. I have to jab them anyway with a scalpel, and so I've jabbed them with the needle, and I made them burn, and I made them cry because it makes you cry, even involuntarily, like onions make you cry. It makes you cry. I just go with the scalpel because I have to poke them anyway, and that is what relieves them. As soon as you make that opening and the pressure is relieved from the abscess, it is almost immediate. I mean, it's still tender and it hurts, but that pressure of the abscess being in a place it's not supposed to be is relieved. It also shows a little pair of forceps going in. And that is likely them trying to break up loculations. So sometimes abscesses can put walls up. And so you like opened it and it's drained, it's great. And you're like, but why isn't it going away? They keep coming back. It's because there might be walls within that abscess and it's not going to drain. So you kind of sometimes do. And this is where the lidocaine might be helpful. You're going to go in, try and numb the inside, and then break down those walls. Packing, which is the very bottom picture, I don't like to do. I like to place a wick. If I feel like someone's going to be able to keep a wound well covered and keep from introducing more contaminants into the wound, I might wick it. And that is just a woven thread of antimicrobial impregnated little skinny gauze that goes in there. And that kind of helps keep other things from getting in there and setting up house, but it keeps the incision that I made to drain the abscess open. I don't want to pack it because I want this guy to fill in with healing tissue. And if I've packed it, it can't do that. But a wick is nice. If you don't think that someone can keep a wick in good shape, then don't stick anything in their abscess. Just let it open and have them do the warm compresses to encourage it to stay open so it can continue to drain. Next slide, please. And then these are all the wonderful occlusive bandages and things that we can use to dress people's wounds with. We got our old school bandages in a lot of different shapes. We've got Tefla, which is nice because it's oftentimes it's kind of waterproof. It's a non-sticky adhesive bandage. The Tegaderm is fantastic because it is an occlusive barrier. It keeps water out. So it's nice to have some of that on hand. Having some gauze so you can make whatever shape you need. instead of just relying on bandages that come with a pre-cut size. So some gauze is really great. So you can fold it, you can cut it. A different array of tapes, whether it's paper tape, a stronger type of tape. My favorite in the whole wide world is Coban, which is the two bottom ones. And I got really boring colors for you guys. It comes in everything from purple to dinosaurs being on them, so you can have fun with your Coban. And then some Curlex if you're needing to do a wrap for the wound that you're working with. It's a good underlying layer, which is what you're seeing in that hand. There's Curlex and then the Coban. Next slide. Hooray, and I'm done. Thank you, guys.
Thank you so much, Dr. Troxler. That was great. There is a little bit of stuff in the chat that I'll just point out. One, as mentioned, that guide that Dr. Troxler has referenced, the like 100-page, very comprehensive guide is linked in there. Our team also developed a safer injection guide. So we have like kind of a more comprehensive one. It's a lot shorter than the big guide that Dr. Troxler has linked or referenced. And then we have breakout ones for different types of injection, whether that's intramuscular, intravenous, subcutaneous. So those are all linked in the chat. And then, and as Anastasia mentioned, we'll make all these resources available on the iEcho platform later today. And then there was a little bit of, I think, interest around cotton fever. So I just wanted to pause and see if any of the folks that left some comments about cotton fever, if they had any questions or if they wanted to come off mute and talk about that. Or if you want to remain anonymous, you can add that to the Menti, but wanted to give some space around that topic in case folks had more to say.
Yeah, I think I'm happy to talk about it. I feel like there's a lot of like urban legend around cotton fever. And just to talk about my own substance use, I feel like I had cotton fever at one point where I was just like reusing old cottons, like rinsing them with water and then drawing up a shot from that. And I think that's where a lot of people are getting this, like, I feel like it's probably some sort of bacterial, like really acute reaction where they're reusing cottons or cigarette filters and then experiencing like immediate sickness. But again, there's just like so much urban legend around like what is cotton fever and what constitutes it. But just encouraging participants for if they're using filters or whatever, the cottons are really just like the ones we give out are just the little bags with dental pellets, dental cotton pellets in them. And that really just blunts the end of the needle. So you're not dulling your needle, you're not like fraying your needle while you're drawing up. It doesn't provide that much of an actual filter mechanism, just because it's not a dense enough material. But yeah, like really acute fever onset, chills, almost like a precipitated withdrawal like symptoms. But you can still have that high and then you're just also feeling like sick. And it sucks. So just trying to encourage folks to like always use new cottons and not be squirrely and keep all their cottons in an emergency bag like I did and then get sick.
Because when I've talked with patients about it, it almost seems to be it's like either I just gave myself a hot shot and I'm in trouble, or this is transient, it's over, and that was just cotton fever. And so it's like, like waiting game, like, okay, one day later, I still feel horrible. This is something that I need to be checked out for. But yeah, I think that just like that we provide them is really important because that encourages like don't reuse these because then that also becomes yeah, you are pulling up contaminants that you are now putting in yourself that we're either going to get some type of skin infection or it's going to go further faster and end up in an ICU admission. So yeah, I love the fact that we give those out.
I think like from harm reduction perspective, also like something to encourage if people are, because folks get really attached to rituals in their substance use. And if they're like, no, I want to keep my cottons, because what if I run out of dope? Having folks draw up, like do their shot, whatever, and then having them draw the rinse shot from the used cotton immediately and then storing that shot for later capped in a new syringe is like better than doing old crusty cotton shots. Obviously still not like a great plan, but is a bit reduces the harm a bit, I think.
Thank you, Bo and Dr. Troxler. Sam, I know you left a comment about that. Just wanted to pause to see if you wanted to add anything as well.
No, not really. I think Bo covered it.
Perfect. Okay. Any other last questions? We'll do a quick pause and then we'll move into our scenario.
I have so many questions, but I also texted you, Dr. Troxler, but I'm just like so curious about your thoughts about like antibiotic stewardship within this population and what that looks like in a like community acquired MRSA versus especially in our like unhoused folks, because I'm continuously giving people like doxycycline for their abscesses and they have abscesses constantly. So I'm just thinking about like how how can we strategize to protect the longevity of like the efficacy of these interventions. It stresses me out. I don't know.
So yeah, because doxycycline, I love that antibiotic. It's really fantastic because it is so multi-useful. There's so many different things, even like oral stuff that it's good for. So it's like it's stem to stern, it's a good one. When it comes to abscesses and knowing people are getting them frequently, I mean, I think a lot of the things like how do we, it starts to lean in on the prevention, and so that maybe we are finding ourselves having to use antibiotics less often. So safer injection techniques, making certain that you've got new equipment to use many times as possible, that you've got the stuff you need to clean your skin with. We're just throwing soap and water at everybody all the time. But the other thing is abscesses really can just be drained and we don't need to use antibiotics. And I said in the presentation, like, I'll do both because sometimes I'll see, but I'm in a clinic, right? People are coming back to me because I'll see something in clinic and it's not ripe. You know, it's a little bit too firm. It's going to be dissatisfying for me and the patient because I'm just going to hurt them and I'm not going to get anything on return. And if I'm cutting into an abscess, I want something coming out. So there needs to be some fluctuance or some softness to it. And it might be that, you know, I'm trying to get them back to see me in a couple of days because they've been doing warm compresses, and then I'm going to take an 11 blade and put it in there and open that guy up. So doing things that we can do that don't require us to use antibiotics as much as possible. And then when we have to go to them, it shouldn't always be just like, oh, red antibiotic, oh, red antibiotic. What else is going on? Is there another way that we can address this? Is this really an infection? Or give me the history of like that one that I was like, that looks like me when I get a wasp sting. Like that's a freaking dinner plate on that woman's thigh of erythema. But you know, if we've got like a 1 centimeter spot of erythema, like let's see how this progresses. I'll draw my circle around it and see what happens. Like, is it tender or not? Like, is this an infection or not? There's so many reasons why people might have red circles on their body and it's not an infection and they don't need an antibiotic, or it's a really mild beginning of something that we can do warm compresses for and fix it and not have to lean on antibiotics. Sometimes these things do really need to be looked at several times. So having those resources where people can evaluate and reevaluate serially to make certain it's going the right direction or not the right direction, and then that's when we intervene with antibiotics. So sometimes these things can be a little labor intensive, and because you want people back. So labor intensive in got to get them back to you. Labor intensive in I'm worrying about them because they didn't make it back. Is it better? Is it not better? What's going on? But we don't always need to pull antibiotics as our first intervention. The best answer I got.
Thank you.
You're welcome.
Greg?
I was just going to add real quick things we've had success with before. So giving out soap, obviously, there's really no medical situation. Like you don't have to be a needle exchange to give out soap to people. It's soap. So like when you go away from a clinic, go home with a doggy bag of soap. That'd be lovely. The little small dial soaps are great because they're small, but the bigger ones that are like 8 ounces maybe, those we've had good use because we'll tell people use them down almost all the way. And then what you can do is you can give them a bottle of water in that, and they can put the water in the soap thing and shake it up. And so they can have like soap water to like rinse wounds and stuff like that if they don't have access to running water. And so little tricks like that. So a participant taught me that one time. And I was like, this is brilliant. I'm going to start teaching everyone this. So different size soap things to give people where they can have access to if they don't have access to running water can be really useful.
Love that. Thanks, everyone. Allie, will
Yeah.
you pivot us over to our scenario? Okay, and as a reminder, we'll stop the recording now as we move into our scenario discussion.